Caring for patients in the ICU and acute care takes commitment. Every day, you strive to keep your patients comfortable and help them get home to their loved ones as soon as possible. These are some of the most vulnerable patients. It's critical to prevent healthcare-associated infection, or HAI, and to help minimize complications associated with respiratory compromise. We're right there with you. Working together, we can help you provide better patient care. Reducing the number of days patients are on ventilators, reducing antibiotic use, and making a real difference in the ICU and long-term acute care. Many acute care patients are intubated for extended periods, and with that comes the risk of complications. The term ventilator-associated event, or VAE, is used for surveillance of the many complications that can impact patients receiving mechanical ventilation. Ventilator-associated pneumonia, or VAP, is one of these complications. VAP is also one of the costliest healthcare-associated infections, as much as $23,000 in expense for each case, which is not reimbursable. A retrospective study completed in 2010, which included 54 centers for care, resulted in a median loss per hospital of $32,140 per patient. This same study highlighted an increase in ICU days from 8 to 18.5 days for those patients who developed VAP. Extended intubation can put patients at risk for impact on the trachea's sensitive mucosa. Friction or excess cuff pressure can lead to irritation, sore throat, cough, ischemia, and potential tracheal trauma. Seal the path to a smooth recovery with SHILEY airway management products with EVAC technology. The unique taper-shaped cuff may help you reduce the incidence of VAP, shorten hospital stays, and reduce tracheal impact. The separate suction port allows for removal of potentially contaminated secretions, which could otherwise be aspirated. In an analysis of 13 randomized clinical trials looking at subglottic secretion drainage, 12 demonstrated a decrease in the rates of VAP, and overall, there was a decrease in the length of ICU stay and days on mechanical ventilation. In addition, 4 clinical studies showed that when the SHILEY EVAC endotracheal tube with TaperGuard cuff was used for subglottic drainage versus standard care in patients expected to be intubated for 48 to 72 hours, the incidence of VAP was dramatically reduced, even when head-of-bed elevation and oral care was in use. Furthermore, the SHILEY EVAC endotracheal tube with TaperGuard cuff was shown to reduce ICU length of stay by 9.5 days, shorten the duration of mechanical ventilation by 4 days, and reduce the use of antibiotics. The unique tapered cuff design reduces the amount of tracheal pressure versus cylindrical cuffs, helping to reduce irritation and sore throat. So let's look at how VAP occurs and how subglottic drainage with the SHILEY airway management products with EVAC technology can help prevent it. In ICU patients, the oral cavity quickly becomes colonized with virulent bacteria. The esophagus and stomach can also become colonized, especially in patients receiving certain medications for stress ulcer prophylaxis. Colonized secretions can then migrate to the pharynx and may be aspirated through the open glottis into the trachea. There, they pool above the tracheal tube cuff, where they may become further colonized. 88.9% of ICU patients have shown evidence of gastric contents in their tracheal aspirates, even with head-of-bed protocols in place. Although tracheal tube cuffs are designed to protect against gross aspiration, small amounts of fluids can leak past the cuff. This is called microaspiration. Microaspiration is magnified by cuff movement due to ventilation pressure or patient movement. When contaminated fluids leak past the cuff, they may be aspirated into the lungs, where pathogens can multiply and cause pneumonia. The use of SHILEY EVAC endotracheal tubes or SHILEY Flexible EVAC tracheostomy tubes is a simple and effective way to remove subglottic secretions that could otherwise lead to pneumonia. Most evidence-based guidelines for preventing VAP recommend removing subglottic secretions with specially designed tracheal tubes. Let's walk through how to use the SHILEY Flexible EVAC tracheostomy tube with TaperGuard cuff. The insertion of this product is the same as a traditional tracheostomy tube. The inner diameter of the SHILEY Flexible EVAC tracheostomy tubes is equivalent to a standard SHILEY Flexible tracheostomy tube. The outer diameter is 0.3 to 0.6 millimeters wider than a standard tracheostomy tube due to the addition of the integrated EVAC port. To prepare the SHILEY Flexible EVAC tracheostomy tube for insertion, first remove the tracheostomy tube from the package. Check the cuff functionality by inflating and fully deflating the cuff. Add lubricant if desired. Then insert the tube into the stoma and secure with a cotton neck strap. Inflate the cuff to 25 to 30 centimeters of water. Do not overinflate the TaperGuard cuff, as tracheal damage could result. Please consult the IFU for more information. The SHILEY Flexible EVAC tracheostomy tube with TaperGuard cuff provides tracheal access for subglottic secretion management in adult patients. The use of a tracheostomy tube with subglottic suction reduces the risk of aspiration above the cuff. You will need a few supplies for caring for a patient with a tracheostomy tube equipped with EVAC capabilities. These may include gloves, an additional tracheostomy tube of the same type, a disposable inner cannula if applicable, a handheld suction catheter, sterile water, hydrogen peroxide, a clean basin, a syringe, sterile 4x4 gauze pads, a tracheostomy cleaning kit, and wall or portable suction equipment. Begin by connecting the suction lumen to the wall or portable suction device using a vacuum regulator. To set the appropriate suction level, occlude the suction tubing completely, set the vacuum regulator according to your institution's protocols, release the suction tubing occlusion, and then connect the suction tubing to the yellow suction port attached to the tracheostomy tube. Typical suction practices may include intermittent suction using a regulator set between -100 to -150 millimeters of mercury. Always follow the hospital or doctor-recommended protocol for suctioning. Since the majority of the oral secretions are harmlessly swallowed and the subglottic space is smaller than other suctioned areas, it is normal to see small volumes and slow movement of secretions through the lumen. A properly functioning suction lumen may remove as little as 1 to 2 milliliters within 24 hours. Aspiration of subglottic secretions does not affect the tidal volumes delivered to the patient. The suction port is above the tracheostomy tube cuff, and the ventilation gas is delivered below the tracheostomy tube cuff. If a blockage is suspected, remove the inner cannula and replace with a new inner cannula. If the inner cannula is reusable, remove and clean with a mild detergent, as outlined in the IFU, and then reinsert. As with all tracheostomy tube cuffs, cuff pressure should be monitored regularly to ensure an adequate seal. A suction cap is provided to prevent contaminants from entering the lumen when you are not performing suction, such as when the patient is in transport. It is important to keep the tracheostomy stoma site clean and dry. When suctioning is complete, be sure to check the stoma site for any remaining debris or irritation. Use hospital-recommended cleaning practices, which may include a mixture of half-strength hydrogen peroxide and sterile water. A cotton-tipped applicator can be used to clean the stoma area at least 2 times per day. Secretions occur in 3 separate areas: the oral cavity, the subglottic space, and the area below the tube cuff. Subglottic suctioning with SHILEY Flexible EVAC tracheostomy tubes with TaperGuard cuff removes secretions in the subglottic space, but not secretions in the oral cavity or those below the cuff. It's important that you continue to perform other needed suctioning and care, including tracheal, bronchial, and oral suctioning. Many clinicians use handheld catheters, which are helpful for oral and tracheal suctioning. Handheld catheters are not appropriate for subglottic suctioning since they are difficult to navigate and are often placed in the esophagus or worse, near the glottis, which can cause damage to delicate structures. By following these simple steps, healthcare providers using the SHILEY Flexible EVAC tracheostomy tubes with TaperGuard cuff may be able to reduce the incidence of ventilator-associated conditions, resulting in improved patient outcomes. We are committed to developing meaningful innovation and sharing information to help you deliver the right care for each patient. Together, we can make a real difference in the ICU and long-term acute care.